Our next speaker is a clinical psychiatrist trained in both psychiatry and neuroscience. His research in the field of stress, trauma, complex PTSD, and neuroscience has resulted in over 200 published papers and over 30 book chapters on the topic of biological as well as psychiatric aspects of trauma. He is strategic advisor of research at the Military Mental Health Service with the Dutch Ministry of Defense and holds an endowed chair in psychiatry at the Department of Psychiatry in Leiden University. He also has an adjunct professorship at the Department of Psychiatry of New York University Medical Center. Currently, he is the principal investigator of a new research initiative on a roadmap for medication-assisted psychotherapy in the Netherlands and Europe, including use of a variety of psychedelics. Give a big hand for Professor Eric Vermetten.
Very nice, Philip. Thank you very much. Thank you for that nice intro. Thank you for inviting me to this first psychedelic conference, this colloquium. And congrats, Philip, on your achievement. It looks very, very professional, and it was delightful to be at the Nerd yesterday. No, what was the name again? The Node. Yeah, not the Nerd, the Node. When I just looked, I sat there, and when I typed in Sweden and psychedelics, the first thing that came up was this conference. So I think, well, that's another congrats to you. However, when I look at the book, I mean, this is beautiful. If you all look at page number... Who is female in the audience here? Okay, listen carefully. Because if you look at page number 7, there's 1, 2, 3, 4, 5, 6, 7, 8 males, and there's only 1 female on your network. So females, I urge you to kind of jump in and join Philip to represent yourself amongst this male group of interesting people. Now, I should be, I'm actually glad to be here, but I'm sort of the 3rd or the 4th choice because Rick Doblin was invited and he couldn't make it, and Michael and Amy Meethofer were invited and they couldn't make it, and they went down the MAPS line and they all couldn't make it, and then he ended up with me. So, okay, here I am. So after 3 US perspectives, I'm going to throw in a European perspective from the Netherlands. Brilliant presentations that we heard thus far. I'm going to take another. Well, my approach is different because I come from a clinical arena. I don't come from a psychedelic arena. I just come from a clinical arena. So we'll focus on PTSD, and then we're looking at how psychedelics or so could be beneficial, or what opportunities could psychedelics have there. So I'll have a disorder focus. I'm modest in this domain because 3 years ago I knew about psychedelics, but I was very, I would say, naive. I was doing my neuroscience research, and I had some interest, but I didn't have the opportunity until I met Rick Doblin at the APA 3 years ago or so. I went up to him, and it sort of exploded. The interest got exploded, and I'll show you in my presentation where we are now. Now, an assumption. I think you all have an interest in psychedelics here, right? I think so, otherwise you wouldn't be here. Now, who is in academia of you? Okay, okay. Who is a clinician in the room? Oh, right. Now, I know that this can be a compromising question, I know. Who has used psychedelics by any form before? Wow. Who didn't want to respond to the question, the last question that I asked? Okay. Who has treated a patient with any form of psychedelics? No, exactly, that's the question, right? So there's a lot of interest, there's a lot of clinical interest, but this is a compound that obviously very few people have actually treated. And that's sort of the call for research and the call for novel ideas to enable this person here and to you to kind of do more work on this. So let me see. This is a team of Dutch clinicians that have embarked just recently on the bandwagon of Mdma-assisted psychotherapy. We just had an opportunity to be trained by Annie and Michael Meethofer in the south of the Netherlands, and this is the Dutch team that is going to conduct Mdma assisted psychotherapy in the very, very near future. And initially, about 2 or 3 years ago, there was only two, me and Tijmen Bostun, who's a clinical psychiatrist, and me, and this sort of has exploded to now, I think it's about 12 or 13 people from the Netherlands. And there's it's not all of them, because some people on the slide are missing. Now, I'll talk to you about the disorder that I work with a lot. I'm working as an officer in the Dutch Armed Forces. I'm the head of research. I see patients on a day-to-day basis and also do research. And I have a professorship at Leiden University where I conduct my research. And this is very much at my heart, the population that's affected by trauma. And we see them in the military when we send soldiers to war. And the Netherlands has just been sending soldiers to Afghanistan, so we have other NATO coalition partners. But these pictures do remind us, and see if I can get this working as well. If I point here, see, these are memories that are engraved into the memories in the minds of some people who've been affected by terrorist attacks, shootings, or this one is the gold dust lady. I don't know whether you can. Whoa. This is Logitech needs to do a little bit better, or I need to do a little bit better. This is the gold dust woman. It is a trick. This is a gold dust woman who was exposed to the 9/11 disaster, and she was covered with this dust, and her name was the gold dust woman. She died just 2 years ago, or 3 years ago. Very well known. And that's, I think it's a terrorist attack in New York. And this is our foreign minister of foreign affairs who is hugging a female who was bereaved after the MH17 plane crash about 3 years ago that was attacked over the land of the Ukraine. Now, just to in the next sort of 30, 45 minutes or so, walk you through the landscape of PTSD, and we'll highlight some of the things that are emerging. A quote that I'd like to start with is a quote that comes from Rachel Hewitt and Joseph Ledoux. What are we talking about when we're talking about PTSD? PTSD is post-traumatic stress disorder, but the thing, if we're exposed to a potential traumatic stressor, most of us will recover. We're resilient. And this is a quote that they come up with. PTSD represents a specific phenotype that is associated with a failure to recover from the normal effects of trauma. So typically what I would do if I talk to students, this is an individual, and here's this potential traumatic event. It could be an assault, it could be a rape, it could be war, it could be sexual abuse, whatever. That knocks you off. But then, are we able to bounce back to where we were before? So most of us, obviously, seem to be able to recover from these normal effects of trauma, but some do not make it back to where they were. Some of us may get stuck there, and you can't help them, or you want to help them to kind of bounce back to where they come from. It's a mathematical model, but you could also use it metaphorically. You can also use it in biochemical research. Cortisol. Cortisol gives an amplitude and is the ability to bounce back from the level of cortisol, the HPA axis or brain response. Is that going to be able to be reflected from a normative response? You can look at a cognition, psychophysiology of other domains. Very brief, this is the pathophysiology of PTSD. And I'm not going to go in detail, but here we have trauma, we have increased level of catecholamines, and then what happens here is a cascade of events that the traumatic event is going to be consolidated. Every event is going to be consolidated. When we are here, we want to consolidate what we are exposed to. We want to remember it, so consolidate. And you like it, and your memory of whether you liked what you heard coincides with your declarative memory. So if you think back of the conference, that was a good conference, and I remembered this and this and this and that. But in PTSD, what happens is there's an affective over-consolidation. If you think back of it, you start crying, you start with fearful response. There's something is over-consolidated. And that's what we see in literature as what we call affective over-consolidation. And there's a failure of extinction of these conditioned responses that can lead to behavioral avoidance of reminders every time you think back of the conference. If there was a traumatic event, then you start to cry or fearful or run away. There can be stimulus generalization. You don't go to any conference anymore because a conference generalized to like, that's a bad thing, if that was the case. So we have the opportunity here, if we look at this from a pathophysiological perspective, we could have the opportunity to intervene very early. Immediately after a terrorist attack, we could intervene, but we don't know what. We have the opportunity to consolidate the memory differently. Or we can intervene very late, when the pathophysiology is there. And a lot of interest is here at the early phase. Like, I just came from a NATO event where we're looking at if there is a terrorist event, like in Barcelona or in Munich or in Brussels, in Paris, there have been plenty. What do we do in the first 24 hours? Of course, safety and find the loved ones, but is there an opportunity that we have? Do we need to give corticosteroids, or do we need to, or nothing at all? We're looking at, can we primary prevent, or no, that's not primary prevent, that's secondary prevent the disorder to happen. Now, these are typical the symptoms. Intrusive memories in daytime or night, you don't belong there. I'm not part of society anymore. I don't go to parties or so. I'm a different person than I was before because I'm not interested. And maybe existential, I don't deserve to live if my buddy has died on the battlefield. Like, why wasn't I killed? I don't want to be here anymore. I'm not part of the society. Panic responses, irritability, flashbacks, and typical with automedication or drug abuse or others. That's just a snapshot of the symptoms of PTSD. Now, I know this is a busy slide, but I just want to highlight something. Now, PTSD was incorporated into our diagnostic system only since 1980. Since 1980, before we named it differently, we had different disorders, we had different names for the disorder. In 1980, we said, let's focus on this is called PTSD. So if you then could look at decades of research, we have 3 decades, maybe 4 decades of research. The first decade of research can be capitalized as the decade of the hippocampus. I just want to throw that at you because every disorder needs to be conceptualized. What is the framework of the disorder? There was a lot of, and I'm focusing here on the decade of the hippocampus. Why? At that time, we had a lot of neuroimaging. We didn't have functional neuroimaging. We had structural neuroimaging, and it had to do with memory, and it had to do with memory, and the hippocampus was connected with memory processes, deficits in memory processes. And at that time, PTSD was a disorder of the memory. And the disorder of the memory was engraved in the hippocampus, so we can conceptualize that as the disorder of the hippocampus and the decade of the hippocampus. All the research was done on the hippocampus. 10 years later, we shifted our attention to the amygdala because we were able to do functional neuroimaging, and we shifted our attention from a disorder from the decade of the hippocampus to the decade of the amygdala. And the disorder was no longer a disorder of memory, but was a disorder of emotional regulation, because that's what was felt was the function of the amygdala. I'm not doing anything, but it's just... And now the attention seems to be shifting to the prefrontal cortex. And now the disorder is shifting to what it is. It's a disorder of the prefrontal cortex, of executive function, of meaning-making. And maybe meaning-making is a different process. So the attention has shifted from the amygdala, from the hippocampus to the amygdala to the prefrontal cortex, from a neuroscience perspective. A snapshot. Maybe you're... Who's not familiar with PTSD from a clinical perspective? Or no, who is familiar with PTSD from a clinical perspective? Oh, great. Well, I'm going to show it to you anyway. This is... Can you start the movie, please? You cannot? Oh, I have to do it. I want to show you briefly a snapshot of what PTSD can look like from a documentary that was made by Peter Kosminski, and you'll see the British troops. Initially, there's no sound, but it'll come as the movie occurs. Sorry, you're doing something. So this comes from a documentary where the British troops were in the former Yugoslavia, and they... And what I'll show you is not what they've been exposed to, but what the homecoming of the British soldiers would look like when they come home. And in the first couple of months, they're struggling with these kinds of events. This guy is trying to go shopping with his mother, and he sees this child, and the child wants to have a lollipop or a doll or something. I think this is Mendel that we're hearing now. This is not the clip of here. Shall we skip it? Okay. So I'll let it play and I'll walk you through what he says. He's sort of seeing this child, and the child is not getting what it wants. And he says, I've seen people with their head shot off. I've seen people on fire. And his affect is throwing him over. There's too much affect that he cannot contain. There's no container for his affect. So he's shouting at these people, and the people are shouting back, you should keep him locked up. He's a danger to our society. But what he's struggling with, he cannot contain his emotions that are like flashback memories intruding upon him, and that he's throwing at this woman. They're afraid of him. And his mom is then pulling him away, like, come on, lad, let's go home, because this is not a place for you to be. And he's completely at a loss here when he goes home, drinking tea with his mom to kind of calm down. Another one, and there should be sound here actually, because you can hear it, is this guy's mowing his lawn. And you typically have heard this when they're mowing their lawn, it makes a lot of noise. Well, helicopters make that sound as well. So he gets triggered by this mowing machine, and that triggers a flashback of this guy and his pregnant wife. He impregnated her, obviously, before he went, and she's soon into delivery, and she's calling up his name. Roger, where are you? Roger, there's a phone call for you. And he's there mowing this lawn, and when she taps him on the shoulder, he lashes out, and kind of his wife ends in hospital. Another one is here, and the sound should be, the sound should be here as well, that there's a stadium, a soccer stadium. This guy who's just returned from the battlefield, he's seen people die, and there's all this shouting, ooh, and here they're all shouting like for the football match, and that's his girlfriend. And you see his irritability is increasing, and he can no longer cope. And there's a moment where he can no longer cope, and he leaves the arena. He has to leave the arena, and his girlfriend sort of, why are you leaving? What's wrong with you? And these are traumatic reminders for this guy, so he stands up and leaves the arena. And she needs to sort of make up a story like, what's wrong with you? There's nothing wrong with me, leave me alone, I'm okay. Let's go home, let's go home. And I'm gonna play it until the end, otherwise I wanna make my point, which is that there's sort of a lack of understanding from an outside perspective of what the inner world represents. She tells him here, like, hey man, I've been learning to play the guitar. I can play Summertime. Let me show you how I've been able to play the guitar in your absence. So she gets the guitar. And she plays him the tune that she has learned in his absence. And he's sitting there, and she plays Summertime, when the weather, that song, right? Very subtle, very nice. And he says then to her, you know what? I'm really proud of you. He means it. He's really proud that she's learned this song. And then her dad comes in. And her dad says, in the opening of the door, you'll see him in a sec. He says, hey guys, glad to have you back here. You really did a wonderful job. Good to have you back, son. And he says, well, I think it was scheite. I think it was scheite, what we did. He says, you were heroes. He said, no, I don't think so. It was scheite. Leaving people to die was awful. And again, the editor has chosen to build this sequence after sequence, and his mind is really at a loss. And he's all with these images and these memories, and he's going back home after the visit to his wife. And you see him now completely at a loss. And we can call that compacted grief. It's a term that sometimes has been labeled in PTSD. Compacted grief. And he's waiting for the bus to arrive. And there's a moment of breakdown. It's like, I do not know what to get me out of here. Because there's no other solution. Now, it's the first time that I showed this clip without any sound. It's quite challenging. I didn't hear you. Thank you. So these are all the names of PTSD. We've labeled names of PTSD. We've called it shell-shock, cytoneurose, l'effroi du mort, KZ syndrome, post-Vietnam syndrome. And interesting, I want to point at you, like maybe the next PTSDs that we'll have in the future are no longer PTSD, but are mild traumatic brain injury or moral injury. Maybe you've heard of moral injury. It's a new terminology. We don't really know what it is, but maybe it's something that we need to explore better. Complex PTSD. Now, this is our framework. I won't dwell on that, but the amygdala, hippocampus, executive functions, prefrontal cortex. We've done PET scan imaging, functional neuroMRI to get a bit of a neurobiological framework of the disorder, understand what's happening in the brain when people have their flashbacks. And here is, it's an old slide, but I want to make a point. If you do a search of PubMed indexed papers in PTSD and you look at how many papers actually have been published on PTSD, and you look at 1980, which is the white line, you see that there is an explosion in the interest, this academic interest in PTSD, in literature. And at the time that I was a resident in PTSD, there was one very popular book, Does Stress Damage the Brain? We had an idea that stress is bad for your brain and does stress damage the brain, and there were like maybe 9 papers by imaging and PTSD, and this idea was very prevalent in my day and age when I was a resident. And in the imaging and PTSD domain, there's an explosion in literature on it. And the book that I want to highlight now that's very popular is a book that is written by Bessel van der Kolk. I think he was mentioned earlier this morning. The Body Keeps the Score. But the field of PTSD is very small. If you look at bipolar disorder or other disorders in psychiatry, the amount of publications are going through the roof. It still is a very modest disorder from a research perspective. I just got this from Bessel van der Kolk. Actually, his book was on the #1 big bestsellers list. It had more copies sold than the DSM-5. And it's now translated in French. And he just sent me this yesterday, Friday, October 12th. He was traveling in Europe and he was traveling to France. And his book is translated in French. And the French called it Le Traumatisme, Problème de Santé #1. Now, okay, let me go back to my country. And this is a country that goes back to 1945. Our country was occupied by the Germans for 5 years. And we were left with a country in devastation. And a lot of people were extremely traumatized. And we had a disorder we called concentration camp syndrome. And this is a prelude to this guy and now I'm making the sort of cliffhanger to psychedelics. This was the first Dutch guy who became very famous for his work on LSD. Maybe you've heard of his name, is Jan Bastiaans. Jan Bastiaans was a professor of psychiatry at Leiden University, where I'm currently at. And he was treating patients with concentration camp syndrome with LSD. And if I can, well, I don't know whether we have sound here. It's an interesting clip of a patient of his under LSD. I should start here, right? No. I hear you. I hear what you're saying.
By an unremitting alertness, the doors of perception
Can I
were
move
continually kept open. In addition, one could not and should not betray one's emotions.
Can I move
These
forward?
could not be expressed at that time, but in the post.
Can I move forward to the video? Yeah, like halfway? I wish I was there. It was there, but I don't see it here. Anyway. I can't see it. Can you see it? Ah, right. Put it halfway. Put it halfway. Just there. More. More. No, way more. 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 Yeah, halfway. Yeah, let's let it play there.
The war itself, but the fact.
He says not the word self, but the fact that after liberation, well, this is in English.
Never ceased to invade living rooms and life. Our experiences of recent years in the treatment of ex-concentration camp prisoners directed us to the use of LSD-25 also for this man. Unlike the old method of hypnosis and narcoanalysis with pentothal, LSD has the advantage of retaining in the conscious mind that which was experienced. We will now show you fragments of an LSD session lasting for 5 hours. At the start of this first trip, we see minor signs of intoxication, such as visual distortions with disturbances of accommodation and changed perceptions of space and time. Cold and warm sensations as disturbances of the autonomic nervous system are, however, integrated in the re-experiences.
This was recorded in about 1967, so 68.
Ja, ik kan niet zeggen wat. Iets wat zich beweegt, wat van me afgaat, met een bepaalde snelheid. Ik heb het idee dat ik hard over een
He's talking in Dutch, and I have the idea that something is coming to me and I want to push it away.
Zie ik op het ogenblik.
Now, this is a beautiful documentary that is translated by a filmmaker, Louis van Gasteren, who just passed away 2 years ago. And the movie is called The Price of Survival. And it's a very beautiful documentary of the life of this concentration camp survivor who's been treated by LSD. And you'll see also the impact that it has on his family. But what I'm point at is he was ahead of his time, Bastiaans. He was refuted later because he continued to use LSD even though it was illegal, and a lot of conflicts arose. But I'm reading his books now again, and I think he really was a pioneer at that time. It's called there a book that's written, The War of Bastiaans. He didn't fight only to get a recognition, but also against academia at that time. Now, why was he using LSD? Because it was so difficult for him to get the affect. People were alienated from their affect. They had no verbal repertoire to talk about their experience in the concentration camp. Yet he was trying to use LSD to bring that affect to the surface and to have a verbal narrative for the affect. And then it was sort of refuted for years, and now we have these evidence-based psychotherapies for PTSD. We have evidence-based psychotherapies, and we have quite a few. So do we need psychedelics actually in the psychotherapy of PTSD? Do we have cognitive therapy? We have narrative exposure therapy, prolonged exposure, brief eclectic therapy for PTSD. We have cognitive processing therapy, and we have EMDR, and they're very effective and they're very popular. Yet, are they very effective? Are they very popular? In my patient population, they're not as effective as I wanted them to be. There's a high dropout, and there's often a non-response to these treatment interventions. Why? Probably maybe because of cognitive avoidance. It's not fun to relive your experience. It's often hard. So if you can keep avoiding what's there, you may be okay. It's a coping style that people can be very good at. This is EMDR. We don't really know what it works, but if you have a single type trauma, and you do EMDR within the first 3 or 6 months after the trauma, wonderful response. It's a very effective response. I'll skip this one in the interest of time. And what we do see in psychotherapies for PTSD is, okay, we have the evidence-based psychotherapies. What we're now struggling with, how often do we give psychotherapy? Do we give it once a week? Or do we give it twice a week? Do we give it twice a day? And there's now puzzling results on what is the best saturation point from a patient perspective. Do we give verbal treatments and non-verbal treatments, like yoga and mindfulness in combination with exposure-based therapies? Do we give a day treatment response? People are exploring what is the best. We blend therapies, and what we're now struggling with is, or in the Netherlands just came a few reports out, if I was Philip's patient, I would like to see Philip the next day too, because we'll build a rapport. If Philip was going to be replaced the next day by somebody else, I would need to build rapport. But is rapport really really important for a therapeutic response? So there's no question: could we do a carousel of rotating patients, rotating therapists from one patient perspective? So do we really need to do that report? And there's confusion. We think that there's one patient because of the trust is very important. It's opening a whole can of worms. Mindfulness, ACT, we see acceptance, commitment therapy, and I think we have a beautiful presentation by Jeff Gross later today about ACT and the blending of therapies. We see these two activity-based therapies where we do climbing and running combined with sitting. Remote therapies, head-mounted displays, and then we have the other one here, medication-assisted therapies, and that's opening up a whole new perspective to the process of psychotherapy, combinations with medication, and we have a couple. Of course, we have the MDMA, we have ketamine. And what does it really target? The word that I want to highlight here is the word reconsolidation. I spoke about consolidation in the early aftermath, and reconsolidation is opening a new arena for targeting traumatic memories. If we remember traumatic memory, the memory becomes labile, biologically labile, and then we could manipulate, quote unquote manipulate, sounds really awkward, manipulate the memory so that it gets restored in a different way. And these compounds like ketamine, that's a beautiful model for how ketamine might work, by targeting reconsolidation. Now shift a few minutes with me. Here we have a disorder that is highly prevalent, can last into chronic symptoms, but there are only 2 medications that are FDA approved for the treatment of PTSD. These medications are paroxetine and sertraline. When were they approved? In 2001. So for the last 16 years, we haven't had any novel medications approved in the treatment of this disorder. Now, various reasons. Maybe the industry wasn't interested. The pharmaceutical industry backing off anyway. The patents have lapsed. So there's no new compounds that are being explored for PTSD. And there's a paper by John Crystal that says there is a crisis in the pharmacotherapy of PTSD. We need novel ideas, novel approaches, novel incentives. Think outside of the box. And these are all the medications, SSRIs, and there's only one that actually had made it to the interest, which is prazosin. It's an alpha-1 adrenergic antagonist for nightmares and sleep. And if you see from over the last years, from here 6.1 to 25.8, so there's an increase in the use of prazosin. It's a very effective treatment. It's not a psychedelic drug. It's a simple, low antihypertensive drug. And we shouldn't give any benzodiazepines. That's the thing you could read from here. There's all these guidelines. We won't go over that. But he asked 27 experts in the US, what do you think are the most promising compounds in the treatment of PTSD? NMDA receptor antagonist, number 1, is ketamine. The second one, cannabinoid receptor modulators, which is medical marijuana, number 2. And there's a list of others. Why is MDMA not there? Interesting, because if you read a letter to the editor in the next issue, the MAPS team wrote a letter to the editor saying, hey, why did you leave out MDMA? And they corrected it afterwards. Oh, sorry that we left out MDMA. Medical marijuana is very interesting compound. And this is a paper by Rakesh Jetley, who is a colonel in the Canadian Army, who did the first Nabalon study for the treatment of nightmares and sleep problems in soldiers. That's been replicated now, and there's more research on the use of medical marijuana. That's not using the reconsolidation model, that's maybe for symptom relief. And I can tell you that I wouldn't say 80, but maybe 70 or 60% of my caseload, my veterans with PTSD, have started using medical marijuana. and they don't want to be tapering off. They don't want to stop taking it because they feel better. They have less nightmares. Their spouses, which is a good indicator, says he's a much nicer man to be around with. And they don't want to be stoned. No, they just want to be better regulated emotionally. So basic notions of PTSD is the reconsolidation perspective. I just want to go over that. Medication, targeting reconsolidation, and ketamine. Now, the model for ketamine is really interesting, and I spoke to Boris yesterday. I'm really concerned now on ketamine. Ketamine has not been tested in the literature for PTSD. It has been tested as a standalone for suicidality and for depression, but the interesting model is in ketamine to give a bolus of ketamine before exposure-based therapies. And doors of perceptions are open, and then maybe the cognitive avoidance is less of a hindrance from a patient perspective. It's not been tested before, but this is, in literature, it's not been tested. But this is the idea. But the challenge is this here. Yeah, the challenge is the pointer, is that the exposure, the reconsolidation needs to occur. It's not just drinking coffee and have ketamine and there you go. No, the effectiveness of the treatment relies on the fact that the SUD scores need to go up. There needs to be reconsolidation, new learning, new meaning making. Now I understand I don't have to be afraid of the snipers anymore because of something I learned. And the new learning is then consolidated in a novel way, and then the effectiveness is there. That's the framework of ketamine. And that's the goal that we wanted to now look at in Leiden. How much do you need to give? And how long before? We don't really know. And we have a concern with all the ketamine clinics that maybe we need to throw the baby away with the bathing water. I don't want to do that, but there's a concern. But ketamine is not the only one. We have a whole list of compounds that we may target to facilitate reconsolidation. And when do you give it? Do you give it before exposure? Do you give it after exposure? We do not know yet, but it opens up a whole area of research that we can look into. Now, if we look at medication-assisted psychotherapy, we have the psychotherapeutic intervention that we need to describe very carefully. We need to describe the therapeutic process. Are we targeting memory? Are we targeting trauma-related memories? And we need to define the essential therapy condition. We need to also look at phase orientation, the timing of drug administration, the proper length and frequency of the combined intervention. Those are things from a scientific perspective that we need to get right in order to define the efficacy of this intervention. Now, and here we have then, of course, the very novel, the breakthrough one, the MDMA. Could MDMA be useful in the treatment of post-traumatic stress disorder? Ben Sessa wrote this beautiful paper already a while ago, and this is the hand of Marcela Outlahora, who gives here the MDMA. And this is the protocol that you may or may not be familiar with that MAPS outlined, the manualized protocol for MDMA-assisted psychotherapy for PTSD. 3 sessions of MDMA. 3 sessions of MDMA only. There we go. This is one, the square. These gray one are experimental session, experimental 2, experimental 3. And in between, there's a preparatory session in the beginning, 3 or so, or 2 screening measures, 3 preparatory session, experimental session, 3 integrative sessions, then another experimental session, 3 integrative sessions, then we have a primary endpoint, and then another experimental session, and then a 2-month follow-up and a long-term follow-up. That is the model that the Miethofers currently have. It's a beautiful model that now has been outlined in literature, and you've seen the results of that, which are outlined here. And I was just last week at a conference with Michael Miethofer, presented these results. And it's beautiful when he describes, now here are the results of placebo, and he outlines this. And here are the patients, the CAPS score before treatment, and he says this is the placebo group. And he sees that statistically significant drop in placebo. And then he says, this is the MDMA group, and he shows them these data. And that is beyond the detection point of PTSD, which is actually, you can say, quote unquote, these patients are cured of PTSD. Now, in psychiatry, it's very hard to say that people are cured, but here you can say they're cured of their PTSD. Now, the setting is beautiful. If you are working in a clinical arena, and I'm working in a clinical arena, this is beautiful. This is not how my typical office or our typical offices, wherever we go, are decorated. That's a contextual variable. And this is the paper from Miethofer. Now, beautiful that this is manualized. There is in the US now 16 active sites, and there's people here in the US that have already started open label lead-in phase before the phase 3. And it's beautiful that the first results are very promising on MDMA-assisted therapy, 2 sites in Israel, and there's 7 European countries that are participating with a PTSD trial. Why is MDMA now so effective? If you ask me, and this is sort of not only personal, but if we talk about it, what these patients, I wouldn't say generalize, but what is so difficult to reach at is the cognitive voice is in their way. And with the PTSD, when doors of perception are open, the cognitive voice is no longer in your way. So the healing can be facilitated in a novel way. It's a different setting. When I train and when I give a college to new students, they're not familiar with 8-hour sessions. It's an 8-hour session. It's long. It's very personalized. It's non-directed, or as the Miethofers call it, it's not non-directed. It's inner-directed. You focus on inner feelings. It's not you go now to your traumatic event. No, it's just whatever. Internal family systems is a model about parts, the protector part and another part, different parts. It's a beautiful model by Dick Schwartz that is being used in the therapy. It's based on cohort principles, humanistic. It is slow therapy. It's not heroic therapy. It's watchful waiting. You have to deal with strong transference. You need to have skilled therapists. And you need to focus on the meaning making. And the beautiful thing that struck me when I first saw the patient is when we do an exposure session, typically the patients have a SUT score that goes to 8, 9, or 10. High SUT scores. Panic, reliving the experience. A reliving experience under MDMA, the SUT score is 0 or 1. And when I'm a clinical therapist, I'm very intrigued with that process. And the sort of quote-unquote healing, it's much more facilitated than the struggle that sometimes patients have. And it is that's a beautiful, the effective corrective experience that you're able to make. A different perspective, maybe a dissociated effect that you can look back on yourself and the experience is corrected in maybe a reconsolidated new way. Now, do you need to take MDMA yourself to be able to conduct this therapy? I think you do. This is my session, and this is Marcella Odlahora, and that was in Boulder. And this is my session where I get my MDMA, and I think it's very valuable to understand what a later patient goes through, and to experience what it is to be accompanied by 2 loving therapists for 8 hours, and to have the verbal vocabulary. And to also understand it from within, what it is that occurs. I can say much more about that, but this is after the MDMA. It's also a lot of fun. And this is our session that we had with Bruce and Marcella after the therapy session, and that's also a part of it, where we have a lot of laughter and a lot of joy after. So currently I'm closing. Where are we? We just had a training in the Netherlands, where we were accompanied by Annie and Michael Miethofer with 70 participants that were looking at videos of MDMA-assisted psychotherapy that they have conducted based on their studies that were published in 2016 or 15. A whole group from 14 countries, 70 people from the European perspective, and some of you have been there at those sessions. And and this is sort of almost my very last slide. When we send troops to Afghanistan and we want to fight them, have them fight wars, I think what we need to do from a moral perspective, we need to give them the best treatment when they come back. And often I see how stuck patients can be. And they try to avoid, because it's not pleasant to be reminded. But the way that they can be helped in a healing environment with MDMA has been very appealing to me. So I'm very eager to start using this method to see if we can replicate in our soldiers and in our uniformed personnel the same results as have been shown in the Miethofer studies and others. So in summary, we tried to understand over the last 2 or 3 decades more the rational base. The cognitive behavioral therapies were very dominant. Maybe there's a shift to more experiential or experiential process-like therapies. Why are we doing this now? And if I just talked to one of the residents in Finland. There's a change from a residential perspective in the novel area of mental health than when I was a resident. We were lured by the industry, and now the industry is backed off, and we are at our own, so we can look at novel interventions and create a landscape ourselves. It may also be implicating the way we structure mental health centers in the future. I showed you several trends that are visible. In Leiden, we'll focus on cannabis, we'll focus on ketamine and MDMA as a research line in the treatment of PTSD. And I don't think it will go away shortly, so it'll be with us for a while. These assisted therapies, we need to look at the drug set and setting, of course, it makes sense. We need to look at the therapeutic process, how it can be catalyzed. What is the mechanism? I like the catalysm, and Kim Kuipers will be talking here as well. And I wouldn't say I wouldn't care about the mechanism, but I care about therapeutic efficacy. I'd like to see whether it works. And later, I would like to do dismantling studies to see if we can understand the mechanism. But when medication-assisted psychotherapy is approved for treatment of PTSD, we need to look at what happens after 2022. There's 4,000 people on a waiting list to be trained from a MAPS perspective. What are we going to do in Europe? If this is so highly effective, how are we going to contain the effect sizes that we currently see? Do we dilute it or so? And do we need to regulate that? And how are we going to do that? That's really a challenge. Are we going to have psychedelic clinics in Europe or so? And how are they going to be regulated then with insurance companies and stuff? It's a challenge, but it's a challenge also to think about that. We need to keep high standards, and we need to watch out for dilution and a thinning of the event if we sort of let it slip away. And I think you mentioned that also, Alicia, earlier in your talk this morning. And the very last slide is this is a beautiful group of people, and these are sort of 70 people who were in the Netherlands, and they were all with us and there's the Rick Dublin in the middle, and there's the MAPS team, and somewhere there's Annie and Michael Miethofer, and these are all eager to learn MDMA-assisted psychotherapy, and it'll make a difference when we're all there. Thank you very much for your attention.
Thank you very much.